More like a product that's basically a liquid implant, if you will. Jackie's getting ready to say something. I know she's like got that look.
Nope.
So I've used 0.2, and now we're starting to get that elevation. Give Kathy that for just a minute. And just like Alan was doing, and you know, Voluma will actually, it's very nice when you do this, it actually brings on that a little more hydration even over the first 24 hours where you get this nice one. Yes. Keep it in the area that I want it, and then I can manipulate it. Yeah, for a second, Kathy, if you would. And as I said, it's really nice. You get a really immediate correction. I just use 0.2 cc correction. So you know, you get this in women and men, I think, for the signs of aging. And you do start to lose, Kathleen has a nice angle, but a lot of women and men certainly lose that as we age.
Yeah, I think facelift patients really, oftentimes, don't you think it's even exaggerated? They lose it?
Absolutely.
It's like their head goes straight into their neck after
Yes.
a while.
Which is never a good thing.
Which is never the goal.
So like I said, it's very, very safe, very easy. Very easy to do. You can do it externally and even supplement internally if they need it. And I usually like to try that before any surgical correction, especially because you can do it in the office and find out if it's going to work. So if you look, actually, you got a little lateral view there. Starting to correct and camouflage the hump, and then we're going to address the tip as well as kind of the concavity at a junction between her bony dorsum and the upper lateral cartilage and the cartilaginous dorsum. So as we see here, and you know, this is a nice thing that you can really get your patient to comment on, so I'm going and help you with, and make sure they like what you're doing. As a general rule, I don't ever put more than one syringe in someone, and very often will not put a full syringe. I get them back 3 or 4 weeks later, reevaluate it, see if we need to add a little bit more. Very nice. You're starting to see that correction on the concavity on the right side. Let's see. Can I turn you? Yeah. You see that right there? That's really starting to do what we're looking forward to do. And it doesn't take much. Let me come over there if I can, okay? Thank you.
Jackie wants to know if we can talk about her tear troughs.
Sure. Yeah, she's had, looking at Kathleen, she has some product, and I agree she has a little light, just a little light Tyndall maybe, but also some blending like Al was doing. I think the option in some of these areas would be possibly to take a little bit of that down and actually maybe address a slight discoloration, possibly with doing a little bit of PRP injection even at the same time at some point. Perfect. And, sorry about that, get it? And then we're going to start, try and camouflage a little bit, give her a little elevation on the infratip lobule. And the Cayumel will give her a little bit of product. And like I said, you'll see that blanching sometimes. We want to just go very, very slowly and wait and even massage it a little bit because the nose is very sensitive to this. But usually it's just a little bit of clogging, if you will, of the capillaries. You can move it right out of that. A little blanching. That's okay. So. Kellen is a youngster, but that's who we see, of course, because we're prejuvenating a lot. You know, certainly, and the unfortunate thing is that cellular aging, we know, starts at about age 22, so already Kellen's just barely on the downside of that, so that's kind of a problem, don't you think?
Yeah,
I mean,
yeah, 23 is rough.
You know. Okay, 23 is rough. We should all, yeah, not a bad thing. But, you know, there's a couple of things, and when you look closely into our evaluation, we try to look at the patient and evaluate them both when they're talking with you, when they're at rest, but also kind of the dynamic movement that you see. So even while you're talking, evaluating, you're looking and you're trying to decide where are the needs, and then also, of course, listen to the patient because they're going to come in and very often tell you. Sometimes you can point a little something out. So Kellen actually pointed a little something out. We were just looking at her lips a little bit, but you know, I like to start at the top and work down. and even maybe try and tell her something's going to make her smile or ask her to smile so you can kind of see how things move. But as most of you know, we form in utero from the notochords, which is the back, and we wrap around and we meet in the midline. And to think that we're going to be symmetric is pretty crazy. And that's exactly why most people need orthodonture, why unfortunately or fortunately, most women's breasts are a little bit asymmetric, why faces are different, why the angles of the mandible are different heights, why ears are different heights. But as long as we kind of maintain that phi proportion, if you will, that Arthur Swift has a great video of the recurring proportion in nature, that phi proportion or Fibonacci number, then you don't notice it. But when someone comes in and we start to look, there's some things that we can notice. So we like to start at the top and work our way down. And a couple things, and again, they're not all these things are things that you want to correct because you don't want to necessarily take away from that proportion. But when we look at Kellen and looking at her, you can see that she has a little bit of asymmetry. Everybody does. Her right side and her orbital palpebral fissures are just minimally different, maybe by a millimeter. And the right side or right cheek is a little bit lower than her left cheek. And you kind of see that as you come down. Go ahead and open your mouth for a second and bring your teeth together. Did you have orthodontia when you were growing up?
No.
Nothing. Good for you. It's pretty awesome. Good. But you can see that, she doesn't really have a crossbite or anything, but you can just see the way that she is there's a slight deficiency in the temporal areas, not necessarily something that we're going to do because I love the shape of her face. But I think that we can benefit her from evening up a little bit of her cheeks in the deeper area. And she also has noted that she's starting to get just some little bitty nasolabial folds, which you can kind of see in that camera. So some of the areas that I see, certainly that she talked about, is going to be her little nasolabial and area. Smile again for me for a second. You can kind of make them pop up a little bit when they smile. Now some people that have this kind of slightly deeper paranasal or perialar area, that will kind of guide us on if we're going to put any of our filler in the deeper compartment, in the supraperiosteal compartment. If someone has a really deep triangle, if you will, in this perialar area, then we can put about anywhere from 0.1 to 0.3 cc's to give you that little correction. But smile again for a second for me. Good. So you can see that she's a little more linear, a little more superficial when she starts to come down and make this little nasolabial fold, if you will. And bring your teeth here. Relax. Good. That's perfect. All right. So if you start to look too, like I said, she's got a little bit of temporal, but not a lot. But when we start to look at kind of the malar area, you can either use Hinderer's lines. I know Paul does that sometime. I'm not going to do her temporal area today, but if it was someone and later on, it's certainly something we may address. But I want to come down and I want to feather this malar augmentation, if you will, in her deep tissue to kind of give her a little bit of this change. Also, when we put in a little more volume, you actually positively affect the nasolabial fold because it actually comes up in cadaver studies. You can really see when you start to fill this deeper compartment, whether you're a little lateral or even coming a little more medial. Now I can't know if this is working. Okay, thank you. So I was trying to edge every little bit out. So we want to kind of come up a little bit higher. A lot of ladies want to come feather down into the submalar area, and we'll see how that is, but we also have to pay attention and bring a little bit more filler just along this eyelid cheek junction, more in her lateral area here. So we'll balance her, bring that up a little bit. We'll see if we need just once we get a little bit in, we're going to put less amount in her left side and correct this area right there. Perfect. And we're looking, there's a very little asymmetry. Again, Kellen actually noted that she has a little less volume. If you look in her lip over here, which we may correct, she's got a beautiful shape. If you look at her proportion, in fact, what you see is that her lower lip to her upper lip proportion is about 60-40, which is the most common proportion that we aim for. A lot of times as women and men age even, the upper lip will start to lengthen, you start to get eversion of it and that lengthening of the cutaneous portion, and you start to lose the white roll. But she really has this beautiful definition where she has a nice sweep up into the Cupid's bow. Now some ladies you'll see have a little more of this straight across lip where it has a nice volume, but others can have a little bit more of what I call these two lateral pillows with a little central raphe. But we don't want to change someone's lip aesthetic. We want to enhance their lip aesthetic. So we don't want to make her ducky by going all the way across, but we would, if we choose to, we'll balance her a little bit here. But if we're going to do some of the upper lip, we'll highlight a little of these lateral pillars and a little central pillar. But not a lot. We want to, again, maintain that shape and proportion. And one thing that you do see if you look on the sideways view, I don't know if we can get that completely. I'm going to get you to turn just a little more, Kellen, if you would, a little away from me. Right there, that's great. So she's close, but you know, really when you look, even though the upper lip usually is a little less in terms of volume, it should protrude a little bit of, past the lower lip. So that's why another thing that we can note, that if we give her a little bit more volume in her upper lip, that even though we're not going to change her proportion, it will probably give her a little bit more of that projection on the lateral appearance. And that's a nice, again, look that you can maintain or enhance a little bit. So she's had some numbing medication on there, some topical. You ready to proceed?
Yep.
Okay, let's do it. We're going to use Voluma on her mid-face and cheek. And again, we're looking at just a little bit, and you know, she's got these beautiful eyes, but again, you can see that her cheek on her right side is just a little bit lower. So we're going to start with our perpendicular. This is an area when I'm going supraperiosteally into the deep fat compartments that I do like to use needle, go perpendicular. I think you have less chance of bruising and a little more precision. So we're going to go straight down. And I use my non-dominant hand a lot, and Paul really was a great example and really showed what you can do. But I'm really holding it in that deep compartment. I know where I am. I'm right on her zygoma as well. And you can actually start to see it pump in there and fill in there. And
notice that Miles is injecting it slowly, which is exactly the right thing to do, because that's one of the things that you can minimize the risk of vascular compromise by injecting it slowly, as he's doing.
Absolutely. And, you know, I'm coming up and I'm trying to blend a little bit. Even Voluma is not a filler that I would use normally in the tear trough. I do think that we can get some nice blending by just sliding a little bit of product. In her case, I'm trying to really have a nice a blending of her lateral eyelid cheek junction. So we have to make sure that goes up along the periosteum, along her tear trough there. And I'm setting that up, and I'm going to come a little more anterior. We do try and minimize our puncture sites, because we're going to minimize the chance for bruising if we do that. Put that little sponge there for just a minute. So I'm going to try and set her right side, the side that really needed a little more of the correction, and then I'll see if we need to set the other side. But you notice I'm also doing this before I do the nasolabial, because some of that is probably going to be affected and improved when we do this.
You know, I remember about 15 years ago, you and I were doing injections for ASAPs, and we started to refer to this as the direct and indirect effect. It's exactly what you're showing, because that augmentation of the malar has a direct effect right on the malar bone, and then it has an indirect effect on the nasolabial, which might minimize the amount of material that you have to use.
Perfect. And as you're saying, I really want to, I don't want to change her look. I want to enhance her look, and therefore I'm going to be a little conservative, but in terms of going down into this deeper pocket, I don't want to keep pushing it out. In fact, what we're going to do from her nasolabial injection is I'll feather some into as a layer into the deep or subdermal layer in there to kind of blend again this portion of her face and give her that nice fill and use the effects of the little bit of the biostimulatory effects of all fillers, in this case HA, to bring some hydration to her tissue. And you'll see what I mean in just a second. We're going to let that sit there for just a minute. How we doing? Starting to really look good. And turn your head just a little. I'm going to move over here, and I'm just going to do that. I actually use a 21 gauge needle to make my little puncture hole. use I used to use a 11 blade or something, but I find that after doing this that I can get a 0.9 millimeter cannula through it, or even a 1 millimeter cannula in. So I'm just going to first go down just slightly deep because she gets slight depth at her perialar area.
What's the plane?
This actually deep just above the bone, because I felt that she had a slight perialar triangle that we can improve. And I'm only going to put about 0.1 in there to kind of start the process, because she was actually pointing to that as something that she did not like. Now I can come out down, and now I'm in a totally different plane. I'm in the subdermal plane.
And that's key. What Miles just showed you is key. And I'll show you, I'm giving an anatomy lecture for the second session. That's the key in that particular area, because that's where the facial artery turns into the angular artery, and you have to be either below it or above it.
So, and in this case, we were both, which was...
I know.
Yeah.
That's why it was a perfect demonstration.
So, we've done that, and now I'm going to actually take the same cannula and I'm going to turn it. And this is a really fun thing. It's a little easier with the 2550, but we'll see, because she has very nice collagen in her skin. But I use this technique, frozen face. Yes. So I think naturally done toxin is really good. Dr. Lawrence gave a great demonstration of that, which is what we want to see. So we do want some movement. So go ahead and crinkle your eyes for just a minute. So she's doing pretty well.
Do you think he'll stay there?
Do that one more time. Yep. It's a little bit more. But the other thing that is of interest, I mean, she has a little teeny bit of temporal hollowing, not very much, maybe just a little bit if we have some extra filler left. But one thing that we certainly have noticed is, as we work our way down, that her cheeks are gotten low, but the transition between her eyelid and cheek has really dropped off, especially in the lateral portion of the orbital rim. So in order to balance her cheek, we're going to go ahead and augment a little bit, but really this area, when I do a little bit of elevation, you can really see the step off. So we want to have a smooth eyelid cheek junction, and we're going to go ahead and do that with filler today. The other part is that she has neurotoxin she had a month ago. We might augment that a little bit, but she has said that she wants to see if we can get her brow a little bit elevated, because as we age, when we start off a little younger, the outer third of the brow is usually a little bit higher than the inner third and the inside. And what happens is when you age, it usually ages more at a pivot. So in other words, a lot of times the inner portion of the eyebrows will start to come up as the outside drops. So short of surgery, one ways to correct this are to diminish the closure of either the depressors of the brow, which is the orbicularis muscles. So we can get a little bit of the chemical brow elevation using one of our toxins. But the other thing we can do, and you'll notice as in some people, that if they have a little bit of deflation, that if you put some volume in there, then you can also get that elevation of the brow as well. So we're going to do a little bit of both, where we'll use a little filler and a little toxin and try and elevate that. And then the most important thing, I think, is going to be to really smooth her eyelid cheek junction. So we're going to put a pretty good amount of filler, but we have to build up from below as well, because that's going to allow us to feather. Because if we just put only filler in this lateral portion of her inferior orbital rim, that you'll think we have that step off. So that's going to take a little bit of amount. One unit. Sometimes a third if I need just a little small amount, but I've completely elevated this area. So what I expect, if we have some uncovered frontalis muscles, that this portion of her eyebrow that I elevate right here should start to come up somewhat looking like so. Okay? And I'm going to do the other side for a second, and then we're going to kind of supplement that with a filler. After that, I'm going to come and I'll use my cannula off the lateral neurotoxin curtain. Now, when you use, of course,